Hi, Assalamualaikum. My name is Nurul Nabila binti Saad, and I will explain about the introduction of the cervical radiculopathy and the anatomy of cervical spine. So, what is a cervical radiculopathy? It is a disorder involving dysfunction of cervical nerve roots that commonly manifests as a pain radiating from the neck into the distribution of the affected root. And it is also known as a pinched nerve due to a compression or irritation, or either both dorsal, which is sensory, and ventral, which is motor roots of a cervical nerve at one or more vertebral levels. Cervical spine consists of 7 stacked bones called vertebrae. The 7 cervical vertebrae from C1 to C7 are connected at the back of the bone by a type of joint that called the facet joints. So there are some muscles that attach with the cervical spine, which is sternocleidomastoid, trapezius, levator scapulae, erector spinae, deep cervical flexors, and suboccipital muscles. So the first one is sternocleidomastoid muscles, which is one on each side of the neck, runs from behind the ear to the front of the neck, and it attached to the breastbone, which is sternum, and the collarbone. This muscle allows to rotate your head side to side and tilt the chin upward. So the next one, trapezius. For the trapezius, it helps to tilt your head upward or move your neck backward, rotate your head right or left to the shoulder blade. Next one is the levator scapulae. This muscle attached to the first 4 cervical vertebra and the top of the shoulder blade, which is scapula. It helps lift the shoulder blade, bend your head to the side, and rotate your head. The other muscles is deep cervical flexor. This muscle runs down from of the cervical spine that allow to flex your neck forward and help to keep our cervical spine stable. Last one is suboccipital muscles. These 4 pairs of muscles connect the top of the cervical spine with the base of the skull. They allow to extend and rotate the head. There are 3 major cervical spine ligaments, which is anterior longitudinal ligament, posterior longitudinal ligament, and also the ligamentum flava. So the first one, anterior longitudinal ligament. This ligament extends from the base of the skull down the front of the cervical vertebrae, and it stretches to resist backward neck motion. The second one is posterior longitudinal ligament. This ligament starts at the C2 and extends down the back of the cervical vertebrae. It stretches to resist forward neck motion. The last one, ligamentum flava. These ligaments line the backside of the inside opening of each vertebra where your spinal cord passes, and these ligaments cover and protect the spinal cord from behind. In the cervical spine, there are also 8 pairs of spinal nerve that exit through the small openings foramen between every pair of the vertebra in the cervical spine. So for the cervical nerve C1, C2, and C3, it controls the forward, backward, and side head neck movements, which is the C2 nerve provides sensation to the upper area of the head. For the C3, it gives sensation to the side of your face and the back of your head. For cervical nerve 4, it controls the upward shoulder motion, and it was one of the nerves that control your diaphragm, which is muscle at the bottom of the rib cage that help us to breathe. And C4, it provides the sensation for parts of the neck, shoulder, and also the upper arms. For the cervical 6, it controls the extensor muscles of the wrist, and it involves in the control of the biceps. C6 also provides the sensations to the thumb side of the forearm and hand. The next one, cervical nerve 7, it controls the triceps and wrist extensor muscles, and it provides sensation to the back of the arm into the middle finger. The last one is cervical nerve 8. It controls the hands and gives sensation to the pinky side of the hand and also forearm.
My name is Norma Sudafiza bint Adraza. So next I will talk about the pathophysiology of cervical radiculopathy. The first one is cervical dysherniation. It is a displacement of the nucleus pulposus of intervertebral disc. We know that nucleus and annulus pulposus together it making form of intervertebral disc. Okay, when the annulus pulposus is moving from its position, means moving out, displacement, it will impinge our spinal nerve and spinal cord. Okay, this case mostly occur at the patient 51 to 60 by the study of Colin Kiwis 2018. Okay, and then the next one is cervical spondylosis. There is higher chance that if the patient gets cervical spondylosis, it will lead to cervical radiculopathy, generative changes that result from aging. Okay, when we talk about the aging, we know that as we age, our bone will less in density, so it will lead to decrease in height of the intervertebral disc. Okay, and also it will narrowing our intervertebral foramen. Okay, because of the narrowing of intervertebral foramen, that's why it will impinge and compress our spinal nerve. some cases can lead to the bone spur. Why it happened? Why the bone spur it happened? Because if there is any inflammation in our body. Next is a ligament hypertrophy of the contribute to the nerve compression. When our intervertebral disc receive more load, that's why our ligament become enlarged. So because of the hypertrophy itself, it will compress our spinal nerve. Okay, next I will talk about the sudden trauma. The sudden trauma, we know we have a car accident, fall from high place, contact sport, which is rugby, hockey, that involve a neck injury. Okay, that's why in the first assessment of the paramedic to help the player football in having an injury, they have to put a neck support because there is to avoid any worse injury happen in our neck. I will talk about the mechanical and biomechanical factor. Okay, this is happen in our daily life because of sitting for long hour, sitting on the chair for long hour. Our posture will contribute to rounded shoulder, and then protruding neck. Also it will lead to this cervical radiculopathy. And then we have a repetitive strain activity. Okay, why this happen? Because of we bending, we lifting and twisting. Thank you from me.
Hi, my name is Iklima Izazi binti Muhammad Rizal, and I'm going to present about the clinical features of cervical radiculopathy. The first clinical features is unilateral neck or arm pain. Pain typically occurs on one side of the neck or arm. It can be sharp, burning, or aching. The second one is pain may spread to other areas such as the arm, chest, upper back, shoulder, or even other parts of the neck. This happens due to nerve irritation or compression. The third one is headache, especially if upper cervical nerves are involved. The fourth one is patient also experiences neurological symptoms such as numbness, tingling, and then reflex may also be diminished in the bicep or tricep. Also weakness in the arms or hands. And sensory changes such as reduced sensation in specific area may occur. These symptoms indicate that the compressed nerve is affecting its normal function. The fifth one, neck extension and rotation to the affected side, worsen symptom because this position can increase nerve compression. Then the last one is abducting the shoulder may relieve symptom. This position reduces tension on the compressed nerve, temporarily alleviating pain or discomfort. In summary, the most common symptom is arm pain, which occurs in 97 to 99% of patients, followed by sensory deficit and reflex deficit. Other frequent symptoms include neck pain, which is reported in 56 to 80% of cases, and motor deficit like muscle weakness. Less common symptoms are periscular pain, anterior chest pain, and headache that only seen in 10% of cases.
Assalamualaikum warahmatullahi wabarakatuh. My name is Naraina Tashanti Zakaria. So today I will present about complication of cervical radiculopathy. So the first one is loss of cervical range of motion. So prolonged cervical radiculopathy may result in stiffness and reduced joint of motion in the neck area. So this limitation may arise from the fibrosis of soft tissue or joint degeneration. So restricted neck mobility can hinder the basic functions such as turning the head, also looking up and down. So in further, it will impact the daily life activity. And one is chronic pain. So some patients may experience chronic pain due to persistent inflammation, nerve sensitization, or structural changes in the cervical spine. As we know, cervical radiculopathy also involved in joint degenerative, which is it may cause the structural changes itself. So chronic pain can significantly affect the quality of life and lead to psychological issues such as anxiety, depression. Also, it will affect the patient's sleep quality, which is patient consistently feel pain. The next one is headache, which is cervical radiculopathy can cause cervicogenic headaches, which is originate from the dysfunction of cervical spine itself. So this headache are often caused by irritation or compression of the cervical nerve roots, but usually that happens at the C1 anterior C3 nerve roots, and the pain typically radiates from the neck to the back of the head or even toward the forehead itself, and this pain making the patient having a difficulty to focus or to perform certain routine tasks in their daily life activity. So the next one is numbness. So numbness can happen when there is a nerve compression of the signal sensory transmission that result in numbness or altered sensation. So persistent numbness can lead to decreased sensory feedback, impairing fine motor skill, also increase the risk of injury since the patient is reduced awareness of external stimuli or reduced sensory feelings on their body. The last one is incomplete neurological recovery. So cervical radiculopathy occurs due to nerve compression in the cervical spine. So if this condition is not being treated effectively, nerve damage may persist and it lead to incomplete neurologic recovery, and this may result in residual symptoms like tingling, numbness, also weakness in the arms and hand.
Assalamualaikum, my name is Nadia Balkis. So today I'm going to explain follow-the-doctor management in treating cervical radiculopathy. So usually cervical radiculopathy can be treated with only the use of non-operative treatment. So this include NSAID, oral corticosteroid, and also cervical epidural spinal corticosteroid injection. So as for NSAID, since the main cause of pain in cervical radiculopathy is inflammation, so the use of NSAID for 1 to 2 weeks can help in reducing pain and proximate cause. Other than NSAID, we can also use oral corticosteroid because it helps in reducing swelling and inflammation around the nerves. As for cervical epidural spinal corticosteroid injection, so a study from Magnus et al. 2024, it has mentioned that the epidural steroid injection help in relieving pain and also accelerate the return to normal function of their patient. So this has proven that in his study, where at least half of the patient with the injection has reported that they feel 50% pain relief after the injection. So next is surgical treatment. So if the non-operative treatment is not working or didn't work, and if the patient has a symptom like have problem with their neurological functions, so surgical treatment is needed. So there are two approaches in surgical treatment, where is anterior approach and posterior approach. So as for anterior approach, it involves anterior cervical discectomy and fusion and disc replacement. So for anterior cervical discectomy and fusion, basically it involves two procedures, where first the surgeon will do discectomy first. So discectomy is where the surgeon will remove all the damaged intervertebral disc, and then they will fuse both of the vertebral body. So the aim is to reduce the nerve that has been compressed. So next is disc replacement. So this procedure involves removing the degenerated disc, and then it will replace with the artificial parts. So the goal of the disc replacement is basically to allow the spinal segment to keep some flexibility and maintain more motion, more normal function. So next is the posterior approach. So this involves laminectomy and foraminotomy. So as for laminectomy, it is a surgery where the part of the lamina is being removed to relieve pressure on the compressed nerves, and then this surgery also usually will be done if the patient has a conditions like spinal stenosis or herniated disc. So the aim of the surgery is to reduce the pain, numbness, and weakness that caused by the compression nerves. Last but not least is foraminotomy. So this is a procedure where the bone or tissue is being removed from the foramen, where the nerves exit the spine to relieve pressure on the compressed nerve. The aim is to reduce the pain and numbness that the patient feel on their arm or leg. So that's all for doctor management.
Hi, my name is Nimardia. So I present about physiotherapy management of cervical radiculopathy using the SOPIA framework, which is stand for subjective, objective, plan, intervention, evaluation, and also the revisions. So begin with the subjective section, where we gather the patient main complaint and history. For example, this patient report that sharp pain radiating from neck to the arm with numbness in the fingers. The pain started gradually about 3 weeks ago and become worse with looking down or lifting the objects. Next is objective section, which is we document the findings from the patients. So for the observation, the postural assessment show that forward head and rounded shoulder, and then range of motion, limit in cervical extension, side bending, and rotation on the right side. We also do special tests like Sperling test and the upper limb tension test were positive, that confirming nerve involvement. Next, we move to the plan section, which is the treatment goals and the strategies. So the goals for this patient: to reduce pain, to improve the neck mobility, to restore the muscle strength, and to educate on the ergonomic strategy. So the plan's intervention include the manual therapy, stretching exercise, straightening exercise, and also the posture training. In the intervention section, for this patient, soft tissue mobilization and TENS were used to manage pain. Neck mobility exercise and median nerve gliding were introduced along with chin tucks and scapular retraction for straightening. And the patient were also educated on maintaining proper posture and ergonomic adjustment in their workstation. So for the evaluation, it involves the patient response to the treatment. After the first session, patient pain reduced from 7/10 to 5/10, and also the cervical rotation improved in 10 degree. So for the revision, we plan for adjustment for future session, which is we can increase the intensity for the strengthening exercise, whether patient can tolerate or not. So this is a result and conclusion from various study on intervention of cervical radiculopathy. So So firstly, look at study by Al-Shami and Bamhai. After the 6th treatment session, participants who receive the manual therapy combined with exercise report that they have less pain and improve the neck movement compared to who receive the minimal pressure and exercise. Next, we have research by Young and College. The results show that both group receive the manual therapy and exercise show the improvement. However, adding the cervical traction did not have any significant benefit. So the study suggests that cervical traction may not have enhanced treatment outcomes, but need for the further research. Moving on, study by Ahmed. The results show that nerve gliding exercise greater reductions in pain and disability compared to mechanical tractions. The finding indicate that nerve gliding more effective than mechanical traction to improve the symptom for patient that has cervical radiculopathy. Next article is by Dandeli and team. The result show that the combination of ergonomic training and therapeutic exercise lead to reduced neck pain and improve posture among participants. Lastly, we have research by Jogati and teams. Patients who receive the cervical traction along convention therapy show that improvement in grip strength. So, in reviewing 5 studies, nerve gliding are most effective intervention for the cervical radiculopathy, as demonstrated by Ahmed, which is significant found that a reduction in pain and disability compared to mechanical traction. While the manual therapy combined with exercise also show the positive result by Al-Shami and Bamhai, the addition of cervical traction did not enhance outcomes. Furthermore, ergonomic training and therapeutic exercise by Dandele provide valuable strategies for managing chronic neck pain and particularly in desk-bound individual. So that's all from our group. This is our references.